Well, the problem is that the problem is who has the authority now. Frank, please explain to us, can this be the reason Mr. Gøtzsche is saying, look at these randomized trials, they show us that they do more harm than good, these antidepressants. Can the doses actually be part of the reason these studies show these results?
Yes, that could be. That could be one of the reasons. We don't treat average patients. So and one of the things is that indeed people are slow metabolizers, very fast metabolizers, and indeed it's very possible that slow metabolizers are really intoxicated by the normal doses that we give these people. So these dramatic stories, and I think these dramatic stories are there. Maybe
in the book as well.
Well, no, but okay. Fortunately, I have never encountered one, but that's my clinical experience, which doesn't count as science. I agree with that. So, so that could be. That calls for close monitoring. That calls for.
I'm still looking at the problem and not the solution.
Yeah. Okay. Okay. So no, but that's one of the reasons that that there is so much noise in the trials. And when you put all these trials together and you do a meta-analysis, you do a meta-analysis at the level of studies, not at the level of patients. So one of the new approaches is to analyze patient-level data, putting all these patient data together and see what happens. And then I think there is stronger evidence that antidepressants do work. But the problem is it's average patients, and average patients do not exist. And Hamilton rating scales are not the way to really evaluate if antidepressants work. You need to look at psychological functions. You need to ask people, and that was not done in studies, ask how they function, what the beneficial and side effects are of these drugs.
But that's a bit strange for people who just read in newspapers articles that you would not study the success of a medicine by asking people how they are doing. So yeah. that is not part of the research protocol, right?
Yeah.
Yeah. Okay.
Yeah. Not in the way that we do it in clinical practice, and that you really like to evaluate, does this help in your daily life? Does this help you with the problems that you're dealing with? That's the question that I ask my patients. In what respect is this beneficial, and in what respect does it hurt you, and do you want to stop it? Affect flattening is a problem. Affect flattening means that you don't experience any emotions anymore, not negative emotions, but also not positive emotions anymore. That's not what we aim at with antidepressants. So we should ask patients, so what do they really do in your daily life?
There is one thing that is very strange, and which you can do a lot to improve on here in Holland and elsewhere. And that is that clinical practice is usually like this, that you start with a small dose of antidepressant, and if it goes well after a couple of weeks, you typically double the dose. And actually systematic reviews of different doses that have not been done by industry or industry-supported psychiatrists cannot really find an increased effect by doubling the dose. It's only industry-supported meta-analyses that have found this.
Everybody's doing this.
Pardon?
Everybody is agreeing with
Yeah. So actually, this is very odd because, as far as I have understood, then if you double the dose of an antidepressant, you more or less double the risk of serious harms. So that's the only thing you get out of it. So why do we have it as a standard that people increase the dose after some weeks? They shouldn't do that. So I'm very much on your side. Very, very low doses if you want to use these terrible drugs.
Okay. So what else do we need to understand to make an analysis of the problem actually Peter Gøtzsche is asking us to think about? What else should we have? You say we need to talk about dose. What else should we have on the table?
I think maybe we could have a little debate. I'm sure it's going to be a very productive debate about whether, like for example, you have gastric acid drugs, proton pump inhibitors, that are the ideal drug because they got a huge effect size, and the trials have reported patient relevant outcomes. That's the ideal drug. Now then there's antidepressants who are way down the line, with sort of messy signal, little signal. There is a signal, I think, but it's messy. Yeah. And the question is that signal, the weak signal, is it weak because there's so much heterogeneity in response, so that there's, it is drowning somewhere in the mass of differences between people, or is it that we all have the same response, namely a very weak response? I think, but then that's not evidence. I think if you listen to the clinicians and the patients and people who tell you their reaction to antidepressants, I think it's huge differences between people in how they respond to these molecules.
So you say actually the interpretation of I'm not contesting the results, but I'm contesting the interpretation of the results
and the
of
way the
Peter
trials were
Gøtzsche.
designed. That's a problem.
Yes, the trials are designed for the average human being.
So they do not contest the very small signal, but they ask you, what is your response to this interpretation? Perhaps it's the heterogeneity of the population which is actually creating these results. Some have really good results, some have really bad, and then in the middle you find a little messy results.
Well, I'm sorry, you may not like my answer.
It's fine.
But that's what people always say when you find out that something doesn't work. Then they say, oh, it might work on some and then make life horrible for the others. I mean, that's not how we have healthcare.
Yes.
We just drop the treatment if it on average doesn't work. That's just because we have these drugs, that you have such a hard time of imagining a totally different world where people get psychotherapy instead, because that really works and helps people cope with life difficulties.
1/3 of the cases.
No, not all. We can't help everyone,
no.
but it is effective and teaches people how to cope with life's difficulties.
Okay, one other issue I'd like to put to Peter, and that is just an observation.
But the same problem with, there are no average patients who respond to psychotherapy. It's the same thing with antidepressants.
Precisely.
There is, now you suggest that many people, the heterogeneity is in psychotherapy just as much a problem.
Well, heterogeneity is what we have with us, but on average, psychotherapy works. It doesn't work on everyone. On average, antidepressants don't work. That's the big difference.
Okay, I got a question for
We
Peter.
get your position.
That's a very interesting question
Thank you.
for both. So the interesting thing is that the meta-analyses very clearly show that psychotherapy and medication actually reinforce each other. The effect of medication and psychotherapy combined is greater than the sum of their individual effects. So that's a very interesting observation, I think.
Yeah, Mr. Gøtzsche, please.
Yeah. Well, let's not go into too much detail, but we are looking. We are looking into these trials right now in my center, and one of the big problems with them is that they are not adequately blinded. Because of the side effects, people know, oh yes, they got a drug, so I better be kind here.
Yeah, you make it very clear,
they're
right?
not blinded in psychotherapy either.
No,
because
I know.
You don't know.
I know. You're right. It's also a problem with psychotherapy, but that's why I'm pretty skeptical towards these studies that show minor differences, because they are not adequately blinded.
Okay, so this is the problem analysis, right? This is what we're talking about tonight. Who says I miss an aspect? Yeah. Very good. Ja, begin maar daar. Nou, ik vroeg die mevrouw.
Can somebody explain me why a million
People are
people
using
in
it.
Holland are using these medicine
Okay.
when they are not not useful, that they're not acting?
1.1 million users, right? 80% of the prescriptions are done by general practitioners, huisartsen. Yes.
So the answer is there's 1.1 million prescriptions, but actually the people that then use the medication as prescribed is between 20 and 30%.
Okay.
And the rest actually never use them. And then when they are about to see the general practitioner again, 2 days before they start taking the medication, so that they can say they...
We're going to discuss that later on, but think, yeah.
No, it's true. It's been researched.
There's a randomized trial, yes.
Very long. Yeah.
As a psychiatrist, and I was actually trained by Jim and Frank, which makes me very proud tonight. I actually wonder what Peter's personal experience with antidepressants is. You seem like very angry.
Oh, this is a psychiatrist for sure.
Yeah.
So,
No.
Mr. Gøtzsche.
No. People's experience with drugs is incredibly important, and we have learned a lot from it. That's not what I am against. I'm in favor of that. But it's very, very difficult in the individual case to say that, yes, this drug worked for me, because you might have become even better without the drug.
Exactly.
You don't know that.
Personal
But she wants to go into your brain, so she wants to know whether
Oh.
you have experience.
There's no access here. What do you mean?
Do you have a personal experience with using antidepressants? That was the question. The psychiatrists wants to know.
Oh, I have, you know, funny question, because I have sometimes felt that I should try these drugs. An antidepressant drug, an antipsychotic drug, a stimulant drug that is used for ADHD, I call it narcotics on prescription, because they are amphetamine-like. But you know, after having studied the harms so carefully, I thought, oh no, I better not do it, because if I'm one of these very rare people who become homicidal on an antidepressant drug, my goodness, I could finish off my wife in the worst case. I won't do this.
Okay, thank you.
May I say something? Because we are the ones who get all the patients you can't treat.
Who are you?
I'm a
the
naturopath,
natuurarts, yeah.
natuurarts. There are a lot of people who go for vitamins. It's a shame that it's about antidepressants here, because there's, I think, antipsychotics is a theme which is more important, because antidepressants you can choose to have, but antipsychotics you can't. We in natural medicine we think differently. We want to make the person as a whole better. Yeah. So we don't look at only the depression. We don't even look at only the disease. No, we want. Sorry. Yeah. No. But I want to. No. This is not a question. But I want to bring this in.
Yes. Thank you.
No, but I would like to finish. What we do is we strengthen the nervous system instead of harming it. It seems like antidepressants is like the insulin for diabetes. My question is, what is the cause? What is the cause of depression here?
Okay. Thank you. Very good point. You say I want a holistic. I want to look at the causes, root causes. Yes. In the back there's a very famous Dutch doctor.
I would like to ask the psychiatrist on the platform and the psychiatrist in the room. Aren't you worried about the messy business of your diagnostic apparatus?
Yes.
Because one patient is called manic and depressed and borderline autistic and schizoaffective, etc. So, okay, you are worried about it. What are you going to do about it?
Well, we've written several books about it, and I think we should do away with our current psychiatric diagnostic system called the DSM, and it should be replaced by something that is much more patient-friendly and describes the human condition, particularly human variation, much better.
Do you agree? DSM go away? Yeah? Okay.
Yeah. Well, I agree. The DSM is complicated. The requirements that we want from a DSM or classification system is very complex, and it has a legal side, it has a research side, and it doesn't work for research. It helps a bit as clinicians, a bit. So the use of the DSM is manifold, but I agree with Jim that it doesn't bring us further, and it has brought us problems in the last 30 years, because it suggests we have depression as a disease, and it has stimulated all this biological research which didn't help us very much, or perhaps not at all.
You concur, you agree with this diagnosis, yes.
That's good news.
Okay, what else do we miss now? So I asked, what do we miss in the yes?
I'm a molecular scientist, or I used to be, and I'm very interested always in the way research is being done. I'm also a patient, so I've also done some research on therapies and how they're being developed. And there's one thing I don't understand, because if I'm on the lab and I'm doing my research, then I have parameters, that can measure. If I want to measure cell growth, for example, I need parameters. And if I don't have these parameters correctly and significantly correctly, whatever, the journal is going to not to accept my conclusion. So how far is the research with regard to depression on the biomedical markers, real biomedical markers? Because otherwise this discussion to me it's nothing really. I'm sorry.
There are no markers. There are. One of the problems with the biological promises is there are no biomarkers. We don't have any. So, okay,
it is okay to look for them. It's okay to do research, but you have to remember there's two types of sciences. There's the science, the quantitative science of physically observable variables, and there's something what we call hermeneutics, which is the science of meaning, which takes place in a different universe where things are not quantifiably measurable, but still very
relevant.
Important. Yeah. And the linking the two is a major challenge.
I'm so sorry. I've also been a patient.
You have to have the mic before you can.
I'm also a patient, right? So what I understand is that the doctor is going to look at my well-being, whatever, and what I'm going to tell about it to say the doctor, and I'm also going to say, I'm feeling better, right? So, but as a scientist, I say, okay, so, but yeah, just this evening, I was speaking to someone in the field, and I was just telling her something, and then she sees friends, and she's gone, huh? That's what I want to say. Don't tell me that you're really listening to patients. Maybe you think you listen, but I can assure you,
You say
don't.
if you can't measure it, you can't know it. That's actually what you're saying. Okay, Mr. Gøtzsche. You did something like this. I don't know what that is.
I think we agree here
Okay.
in the panel. So.
Thanks. Two last, and then we're going to continue with the panel. Yeah.
I also think what you described in your book, but influence of money.
Yes, we're going to talk about
money and marketing, and I think there's maybe some discussion for how big it really is.
Yes.
You call it organized crime, and I think that not everyone realizes how big the influence is and how it came so far in a way.
Yeah. Yes, we're going to talk about that. The financing of the research and actually the practitioners who are actually marketed. Missen we nu een heel belangrijk punt, zegt u? Even,
Okay.
Komt zo wel.
I'm missing a very important point, and that's actually the start of the data where Dr. Gøtzsche is talking about, because he was citing several studies, and I'm a scientist, I'm very well aware of all the literature, or much of the literature, not all of the literature, that's impossible, but lots of the literature in depression. And what struck me is that he's citing very old studies, he's incomplete, he is at the same time picking cherries from what he sees in the studies, and then that is not something that the Cochrane Library, Cochrane collaboration is telling us to do. So if I look through his slides, sometimes he's forgetting placebo and he's not mentioning it. He's reinterpreting the data in an unscientific and very dangerous way, and in that way he's a demagogue. And I think in that way we can't start a discussion.
Okay. Can you tell, because you're so aware of all the data, which research, for instance, was really forgotten? You say we really need to look at what?
He's quoting the Rosenbaum study on the withdrawal of antidepressants. He was not mentioning at all that this was a placebo-controlled study meant to show that there are differences between drugs to have withdrawal effects.
Yes.
That the study actually is showing that there is an increase in depressive symptoms, what they measure with the Hamilton scale, and Dr. Gøtzsche is taking that out. But the authors already indicate that this is not the recurrence of depression. Dr. Gøtzsche is saying that actually this studies show and say that these people have recurrent depression. That's not what the study says. Dr. Gøtzsche is also mentioning that antidepressants cause suicide. There's very, very good pharmacological data, pharmacodatabases, which show that the level of suicide attempts is much higher in the weeks before people start antidepressants than thereafter. And I think all this kind of data is not suiting the picture that Dr. Gøtzsche is saying, is wanting to show. And I think that is a very unscientific way.
That's the most fundamental critique, and please.
Yeah, that is really a mouthful. The reason I cite old studies is that atropine was put in the placebo only in old studies. The industry would never allow this to happen today, because then we can all see that the drugs don't work. And to accuse me of cherry picking, now it's my turn. You have had yours. To accuse, what? To accuse me of cherry picking, I don't know whether to laugh or to cry. I have worked systematically with science for at least 30 years. I have mentioned the best science I could find in my book, and now you talk about the Rosenbaum study, and I didn't have time to explain everything about this study tonight. My main point was to show that Hamilton score went up at least 8 in 1/3 of the patients on short-term half-life drugs, which is incredibly disturbing to me. And you must notice that this drug was financed by Eli Lilly. So they have all the reason in the world to say, oh no, this is not a recurrence of the depression. But how do you then explain that Hamilton increases more than 8? That's what we usually use to say that now the depression has come back. And then you say, then I am talking now, and then you say, I was forgetting about the placebo. I don't know where I was forgetting about the placebo, but you can write everything you need in my book. So this attack is totally unfounded. And then the last thing about that suicide risk is worse before starting drugs. That's totally irrelevant, because when you start drugs, you start either drug or placebo, and then you can see what happens. And the patients are comparable in the two groups, and this is what I've done. So I'm just totally flabbergasted by your comments, and then you call yourself a scientist.
No. Okay, no.
This is no.
Oh, wasn't that what he said?
No, but it doesn't matter. This is.
Well, I think the point, one of the little points I tend, because there are, of course, pharmacoepidemiology is also a branch of epidemiology that is respected. And pharmacoepidemiology, particularly in the Nordic countries where you have big brother systems, where everything on every person is registered, you know, his antidepressant medication use, his suicide, his hospitalization for attempted suicide. So those studies have also studied, of course, the association between antidepressant, antipsychotic and other psychotropic medications and these outcomes. And the picture they yield is not the same as you have shown from the randomized controlled trial data, which I think is interesting, because there seems to be a difference there. Why? We don't know, but randomized trial data are very special data as well. We know that there's selection, there's all sorts of processes that make them less generalizable, and these pharmacoepidemiological studies also make a point.
But the thing is, we can throw meta-analysis to each other, showing this. You didn't mention the Eric Turner paper.
Okay, no.
There are so many papers, so
I'm not
this is an
going
endless
into
discussion.
that. I want to, because it's a feisty debate, right? Which is great, because in the Netherlands we usually don't do that. Only on the subjects of migrants. And yeah, really.
Well, we're from Maastricht. We're from Maastricht.
And it needs. You need to have. You said it as well at the end of your presentation. You need to say something with quite some, let's say, stipulation to actually get somebody to respond to you actually and think what if they are right or wrong, and perhaps they have the wrong premises in their head. Okay, so. One person from the audience was asking some attention to one of your why. Why is all that research not valid. And he said the book before this book was actually about the financing of research. And he wants to know whether, if you can say a little bit about that. Is that, according to you, one of the biggest reasons why we are dealing with this issue now?
Definitely. I'm the first that called it organized crime.
Mafia.
What the drug industry is doing, and I haven't been sued for it. I can guarantee you they have held meetings about me and concluded that I knew what I was talking about and I had all the references, that there was no reason to drag me into court. So it's absolutely correct that not only I, but a lot of other people, including former chief editors of New England Journal of Medicine, Lancet's editor and so on, we have all realized that drug research is more or less completely corrupted by big pharma money. So we need as doctors to come into the driver's seat again and say we won't collaborate with the industry any longer if it's on industry's premises. We can do drug trials, but only if the industry has nothing to do with them. That's the future.
Response. Why do we accept that?
Well, I think it's a very good question. So the problem is that we are all responsible because we accept we live in a society where we decide that drug development is a commercial enterprise, and we live in a capitalistic society where universities are not supposed to do this kind of research.
But Mr. Gøtzsche is showing us in his last book, the previous book, and also this book, the risks of that choice, that political or societal choice. Do you agree?
I agree. We need another system to do that. But as Jim says, we are all responsible because we vote governments that say we need companies and so on. So this is a very big problem.
If we want to change it, we should vote differently.
Yeah, we should do more.
But we can also.
No, but we should do more publicly.
Yes.
I agree.
Bad things happened.
Okay, so that is a really important point to put on the political agenda, which is not now on the political agenda, right? Okay. The other thing was
because one thing. The sad thing now is that there's so people have moved on. So there's very little investment now in research, either from the university or the drug companies, because they've made their monies, the big profits were made, and they've moved on to pastures new and green, oncology and cardiovascular medicine, and the thing is, there are also successes of pharmaceutical research. We should remember that as well. And there's an enormous amount of money worldwide. I think like $70 billion a year for research alone. So I want to have that money for research.
Me too. There are of course. I know there is an initiative of a corporation of research doing this and trying to find another
the European Union has done that,
market model or community model or research model. Yeah. Okay. The other thing which we haven't discussed yet, you said it in part of your response to Peter. You said that is really important to understand. We should let these doctors have the lowest dose possible if they choose to do it, and not automatically higher the dose, right? That is really important to get that into between the ears of practitioners. Is that a standard thing which general practitioners and psychiatrists realize, that they shouldn't double the dose after a few weeks? That is something still not discussed.
I think mostly we don't. There is research. He is really a scientist, by the way. Eric, he did research on that, and he showed that doubling the dosage that was paroxetine wasn't very helpful, and it's not useful to do that. It depends. There is an antidepressant. You can measure blood levels, so that's not about dosage, but that's about finding out the blood levels in the patients, and then you know which can be helpful. So it's I agree.
And then all of you were agreeing with your analysis of the right dose, right? And that is a problematic aspect of using these drugs anyway. And we can talk how much influence it had on these randomized controlled groups, but it's also really beneficiary for patients if they could actually have the right dose. So the question is, why isn't that happening?
Because basically we haven't developed the tools to do that. As long as you have to deal with these 3 different doses, then that's what people generally are going to get. As if you have more, it's like with the shoes. If you have only shoes in size 30, 35 and 40,
But how are
then
we going to get
everybody,
that? Yeah, I understand the
because we have to make them available to people and to doctors.
And what steps need to be taken to actually change that, to make that
Actually,
happen?
Peter has made an invention. He's too modest. Peter, I think that's why it's important that people who are users are involved in the research, because he invented a tapering strip that provides
I can show
doctors
the
with
picture if it's
doses
on.
to not only taper the medication but also to find the right doses for each patient.
I can explain it. It's very simple.
So, and that means that you can buy, is it then 5, 6, 7, 8
I'll show
grams?
you. I'll show you. The system we use is like with the coins in your wallet. You take different coins. Oh, wait a moment. And then what you do is you give people, this is an example, to help people stop using psychiatric drugs. In this case, this is the example for paroxetine. You start with 20 milligrams, you give him 1 tablet of 20 milligrams. And then you go to 19.5 milligram, and then you give 10, 5, 2, 2.5, just like with the coins in your wallet. And then you go on, and then you can nicely go down very slowly, in this case from 20 to 10 milligram in, say, a month. And we package that in a Baxter strip. That is all available. It works. And what you get is something very interesting. You get a system which you can call standard decision making. A number of patients can stop using the standard medication.
Yes.
That is for instance, fluoxetine. Almost everybody can do that. For a medicine like paroxetine, nobody can, because it goes too fast. And then you get the following. People can choose
In what time?
At 28 days, 65
Yes.
days.
Of course.
And that changes the story the doctor tells to the patient. The doctor tells to the patient, you want to stop your drug. I know that you have to do it gradually, but I don't know what is the right time for you to do it. And the problem also is that you don't know it yourself too, but you are the one who can best decide how many risks do you want to take, how fast do you want it to go. So you empower the patient, you make life easier for the doctor.
Yes.
And this is what you get. And then as you go more to the end, you see on the bottom level the average dose reduction. You go slower near the end, which is very important to do it. And
this is a way to prevent withdrawal symptoms.
Precisely.
And reducing.
And the people who have used them, they tell us that they are happy and it works much better. Also the people who write me emails like, I have done this and I've been stopping, it went fine, and 4 or 6 weeks later I am having troubles again. Then if they have trouble again, probably
it's not withdrawal.
It's not withdrawal systems, they have other problems, and this might indicate that they really benefit from antidepressants. And this is a much better way, where patients have a saying, to get further.
Thanks. It's unbelievable that this much detail is not possible, and with dogs we actually have it. Interesting thing. We're going to go to the last round now, because everybody looks at their clock. Really? Yeah. Really. It's 10:20. So I'm going to go to the last round, and that means that I'm going to give the mic only in the audience to somebody who says, I cannot sleep tonight if I don't pose this question right now, plenary. You can talk to each other at the bar, perhaps the speakers are there. Sir, then it's your prerogative to give the last comment, ask the last question.
Thank you very much for all your interesting views, but I have one question I would like to put at the very end. Dr. Gøtzsche, you Are there any instances of depression in which you would advise antidepressants?
Are there any instances of depression where you would advise to use antidepressants? That was my first question.
Only if someone is trying to taper off antidepressants and it comes too quickly with too much abstinence symptoms, then the dose can be increased for a little while before you start going down again. But to recommend antidepressants for a totally new person, I can't see the justification for that. And you might think this is extreme, but I built it on the science I have studied, so that's my conclusion.
No, we're not going to do that. Thank you. Yeah, that was the question. And what?
Does the rest of the panel agree with
No,
Dr.
but it
Gøtzsche?
was the first. It was the first. Sorry, it was already my first question about this. Yeah.
I should like to know from the Maastricht part of the panel, what percentage of patients get medicine without any need? And it's not only a matter of non-compliance, that's not an answer, I think.
No. So how many people in the Netherlands, we already had a bit discussion about the numbers, but if we talk about antidepressants, it's 1.1 million prescriptions. You say only 25% is used, the other one is just stashed away somewhere. But what is the percentage of people who should not use the drug who actually get the drug or use the drug? That's the question from the Maastricht.
So,
what do we know?
What we know is that
we don't know.
It's 1.1 million. Half of those, we know the indication is depression. The other half are all sorts of other indications, from pain to sleep or whatever. Anxiety. We have tried this actually, Aart-Jan Beekman and a little group. Last year we tried to calculate on the basis of the epidemiology of depression and the needs associated with the different levels of depression we know from epidemiological data. And we sort of calculated that instead of 1.1 million, and then half of that, the depression at least, it should be maybe a fifth of the ones who get it for depression, we estimated, had the right indications. That should be the right number. Okay. But that was an informed guess.
So we have a large
mental health problem. Yes. Sir, what do you want to add on that?
I basically think what I said, that we don't know, but my guess it is more than we estimate.
Okay.
But this is just a guess.
We don't know.
Yeah.
So luckily, we don't know everything yet, because otherwise all these scientists are out of a job. Yeah. We need to find. Okay. So I'm going to now ask the panel for famous last words, because we're very honored that you were willing to discuss this, well, interesting topic tonight. So this is the moment for your famous last words before you head back to Maastricht or The Hague or Denmark. What haven't you mentioned which is really relevant in the context of this discussion tonight, which should be addressed before we can go to the bar?
One thing.
Okay, one thing. We start with you.
Well, my message is that treating a patient with depression is something a doctor should do together with the patient, and the doctor should listen very good to the patient, and the patient should have real choices.
Yes.
And the system should be developed such that it is made practically possible.
Yes.
That's my message.
I heard you tell on the radio even that for cardiac things we have all these apps which help patients now to really monitor their health. And you say we can use the same data methods to use mental health.
That.
Yes. Thank you. Yeah.
I'm glad we have antidepressants, because part of my patients are really helped by it. They don't commit suicide and they feel well again and can function normally again. So I'm very lucky we have antidepressants with all the risks and complex things involved, but I'm happy we have them.
Okay.
I really
and you're not paid by them.
No. I have no disclosures. No. No advisory boards, nothing.
I would really wish the next book by Peter Gøtzsche would be co-written with Peter Groot. And I think it would be a much better product.
Oh, you say, let's also use the practical information stories of patients can offer.
Yes, I think there's an expert trap. We always talk about patients, but patients rarely are cited in the press.
But in the book there are lots of portraits, of course, of patients, stories of parents. Mr. Gøtzsche, famous last word. Thank you for being in Amsterdam.
Well, thank you. The biggest problem is that we have become used to believing in a lot of things that the drug industry has carefully concocted for us. And this is why we have so much difficulty giving up on antidepressants, because we have been brainwashed by drug industry propaganda and flawed trials and fraud in marketing and corruption and all the rest of it, so that we have come to believe that antidepressants are much better than they are. That's our main problem, because all psychological research shows that if you have believed in something for a very long time, when you are then being given convincing evidence, which I thought I had done, people just become more ingrained in their beliefs.
Yes.
That's how psychology works for us. So this is our biggest problem.
Well, this wasn't the last time we're going to discuss this. Probably it's a discussion we still have to continue. Thank you so much, Mr. Gøtzsche. Let's see if we're brainwashed. We'll talk about that with a drink at the bar. Thank you so much for being in here. Give them a very big thank you. The panel of tonight.